Welcome to the recall session for the last NEET exam, which could be term NEET SS 25 or 24, whichever way you want. But this is a very fiery, pacey exam that we've had. It's more or less very similar to the WACA grounds at Perth. That's why I put up the photo of the WACA grounds. I don't know how many of you can resonate this because some of you may not be even following cricket, but it's one of the most quickest, the paciest, the bounciest, and the fiery ground as far as cricket is concerned. And we've had some extraordinary spells of bowling by bowlers like Curtly Ambrose, got 7 for 1 there and destroyed batting attacks. Just like that. So that's how fiery and destructive the WACA ground is. Currently, cricket is being played at a different venue at Perth. Perth is somewhere in Western Australia. So it's this WACA ground stands Western Australian Cricket Association Stadium. So there's a gentle sea breeze blowing as well, which makes viewership really spectacular at the WACA. So this exam I would always compare with a lot of the matches that have happened there because of the sheer swing pace and bounce. It was a very tough exam. Nevertheless, let's try to be straight at the point. It was a tough exam for the reason that these tables have toppled and changed between the years. So when we set out with this whole platform in 2021, I told you it was a different exam format, 50% subject and 50% medicine. Then in 2022, they launched the exam, the current pattern exam, and this is the third of the exams. And none of these exams have got anything to do with each other. The question weightages have had no consistency. The subject weightages have had no consistency. Preferences to chapters have had no consistency. So that's why I always believe, and I keep reiterating this again and again, that our app or platform is basically for good solid medicine learning, and it's not just for this NEET SS exam. NEET SS exam is one among the so many things that we try to achieve through our learning, and there is no specific preparation strategy as such. And if you're trying to learn capsules and crack this exam, you will be found completely wanting. So if you think as a medicine person, look at the questions as a medicine person. That's why I have taken up all the questions for discussion this time. I'm just trying to see how you can answer this. I'm forgetting for the time being that I'm a nephrologist. Absolutely not thinking of that. I'm just seeing these questions as a medicine person. And once again, requesting you to use the app as your base or your platform to learn medicine. Because I told you this umpteen number of times that 10 years, 15 years ago, when people were doing their post-graduation, even our seniors whom I'm talking of, never used any platform. They were just stuck on the ward. They were looking at cases, seeing cases, discussing these cases, and reading Harrison to pass their exam, which is their theory exam, final year. When we came into the picture, it was all the same. We were using a bit of specialty books here and there, but the core was always to work in the ward, discuss cases with your seniors, accordingly to look at the flow charts or maybe see guidelines, etc., etc. But from that point, unfortunately, the PG course that we're talking about, internal medicine course, has deteriorated so badly many a times. It is now plunged into a level where many a times the students have no guidance, no focus, nothing. And they're stuck with the idea that, yes, we have to read Harrison before we complete the course. And what medal are you going to get from the government for that? Nobody knows. The whole point is not about reading Harrison or not reading Harrison, etc., etc. The whole point is about being sure with your medicine. Because if you get into a specialty, like for example gastro, tomorrow you get some rank and you get into gastro, then your entire medicine is going to go for a toss. By the time you finish off gastro, then the only thing that you'll be knowing is gastro. And whether that will actually take you somewhere is another question that you need to see, because then you'll be having this whole intervention to patch of newer and newer procedures coming into being, and most of the other people in medicine don't even know the full form of these procedures, like the POEM procedure or the BRT or all these things, whatever. So what I'm trying to tell you is that we have 3 years to learn solidly, and even after that to learn solidly, so that we have an understanding of medicine that will hold us in good stead throughout our career. Because primarily we are all medicine people. We're just forgetting the fact that Nishant is a cardiologist or I'm a nephrologist. I'm not thinking that way at all. We're just primarily thinking that we are medicine people. And NEET SS exam is one among the other things, that many things I would say that we need to achieve, or if you want, you can achieve. Because 10 years ago, it was like if you get an NEET SS seat, then you are safe, because you're going into a group which has very few people and which has a lot of demand. Whereas right now, NEET SS is an option. You can take the option, or you very well cannot, or very well need not, because you can very well stay with medicine as well, because there is no hard and fast rule now that if you take up this subject as a career, then you're going to flourish. It need not happen, because there are so many specialities where prospects are actually very minimal. There are specialities wherein prospects are there, but the numbers are so huge. So it's like you're again starting a race, and wherein you are at the bottommost portion, and you have to slog and slog and slog and come out. 3 years are not going to place you anywhere. If you look at a subject like nephrology, in 3 years, you just have an overview of dialysis, peritoneal dialysis, hemodialysis, transplant, glomerular diseases, AKI, the critical care part of nephrology, the intervention part of nephrology, and then the whole general nephrology and the whole CKD. So there are so many entities inside this. So it's not even possible practically to even have a glimpse of this. Like people like me who have entered the course have already entered finishing Fihali, Donovich and Dogridas. We went into the course having studied a lot of nephrology. Now you are entering into the course with this basic medical knowledge. That means that this process is going to be even more tougher for you. So thinking 10 times before taking a course, before going into specialty, is obviously needed. And for that reason, I'm telling you that there is no specific separate plan as such for NEET SS. We are going to do medicine wholeheartedly, 100%. And we are going to see from there where that takes us to with respect to NEET SS. Now, for preparation, this being an app, and this app has to cater to the preparation needs of NEET SS, we obviously have a separate folder which has been named as the High Yield Series folder, which will be again updating based on the current exam and these set of things that are happening now, because we're having critical care, oncology and pulmonology being taken out of the mainstream, etc., etc. And then we have our medicine video. So at the end, I'll probably try to explain to you how to use that with respect to preparation for NEET SS. But again and again, I'm telling you, going and searching into the corner of a book and trying to figure out that, okay, this has been asked, but that doesn't mean that you can learn the whole thing. There were 3 questions on statistics, but much easier would be to have bare idea on what this is based on the thesis that you have done and answer those questions, because those questions really are just basic 3rd year, 4th year MBBS level questions. Odds ratio is equal to relative risk, or what is a type 1 error. For that to sit and study statistics, it's absolutely not required. 2 or 3 questions on poisoning, which I think if you have worked somewhere, you will be able to answer. So it's not necessary to like toil too much. Let's get into the exam questions as such. Some are of course very tough, and that's why the margins are also very narrow in this exam. If you look at 150 questions that have been asked in this exam, we look at the distribution and things later on, but please do understand that somebody who has scored around 400 marks, okay, 400 marks out of 600, which is nearly equal to 2 by 3 or 66%, has got a rank of somewhere around 500. So a rank of somewhere around 500. So that is about to actually kind of telling you that if you get 110 questions right and 40 questions wrong, you will come with a rank of 500. So 110 questions and 40 questions wrong is not easy in this exam. And I'm happy and proud that so many people have achieved that. That is under 500. The moment you go to 450, okay, the moment you go to 450, that is 120 questions right and 30 questions wrong, 120 questions right and 30 questions wrong, which is around 450, your rank comes to somewhere around 35. Yes, so between rank 35 and rank 500, we have a margin of only 20 questions. Sorry, margin of only 10 questions, which is a huge difference, huge difference. That means in a matter of 10 questions, rank has come from 35 to 500. Okay, and approximately 435 is equal to rank 100. So 435 is equal to rank 100. 420 is equal to rank 200. So 420 is equal to rank 200. So it means that the margins are actually very narrow, and you really, if you have got a rank of say 400, 500, you need not feel utterly disappointed, for the simple reason that there is nothing much to choose, and there are a lot of lottery questions which on a given day you may answer correctly, another day you may not answer. So it is definitely not taking into consideration your overall medical knowledge and how good you are. I would never say that a person who's got rank 5 in NEET SS is a really brilliant student, is going to be an asset for India tomorrow as far as the medicine stream is concerned, and he's going to make it big in medicine or cardiology, neurology. I never say so, and I never believe that also, because this is game of numbers and luck and lot of factors. So basically, don't have to think that way. But this is one part of progress. That means if you have already set to the back of your mind that you want to become a nephrologist, your idea is very clear, the reasons are very clear, and the path is also clear, then of course you have to write this exam. Just have to take it that way. But you shouldn't be coming from a tier 2, tier 3 city, planning to go and settle in a tier 2, tier 3 city, and then going and doing nephrology from a tier 1 top corporate college or from a top medical college, and then coming back from there and finding yourself lost in your city. This is what happens many times. Not getting the job that you wish for, not seeing the cases that you wanted. You come to this tier 2 place and start practicing somewhere, see a lot of CKD, and get utterly disappointed for the fact that this is not the nephrology that I was envisaging. And when you're working in that college, you were not happy that time because you were not getting enough time for yourself, space for yourself, work-life balance, blah, 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 etc., etc., etc. So that is why prioritize, have it very clear at the back of your mind what you want to do and how you want to do and why you want to do. These are the numbers, which means that 120 questions will put you in a very safe space. 115 questions is also like more than good enough, because 115 is equal to 460. 460 minus 35 will take you to 425, and 425 is also going to fetch you a rank of somewhere around 200. So even if you manage 110 as well, that is kind of pegging you back a little bit, because 110 comes to 440 and 40 is 400, and then suddenly a lot of people. So it's like very, very narrow margins. So basically, that's what I've been again trying to tell you. These marks and these ranks are not exactly proof of how you are good as a medicine PG and how much you're going to do good in medicine. But this exam has had no real strategy as such. They're just trying to, take up the level, up the level, up the level. But again, that is with a lot of salt that you can actually take it, because you really don't know which subject would have what weightage and how things would change, etc., etc. So that's kind of very hard to predict as well. Let's look into the key differences that have happened in this particular year. So the key differences that have happened in this particular year is the people who lead the show. So people who lead the show are completely different this time around. Let's see how that is. So when they have made this change with respect to taking out the pulmonology, critical care, as well as oncology from the mainstream, that means that now you have cardiology, you have nephrology, you have neurology, and you have endocrine. So I expected that majority of questions would actually come from these 4 chapters. So this is what I actually expected, which means that this you have to study in big detail, because last time around cardiology was so much, neurology was so much, and neurology was extraordinarily tough, etc., etc. But they changed the tables completely. They, in fact, decided that let most of the questions come from MG, rheumatology, MG and liver together, rheumatology and infectious diseases. And what happened is hematology, oncology part, which they thought is actually equal to oncology. So they didn't ask anything from there. They asked 8 questions from pure hematology. So let's like to just see the distribution. So infectious diseases almost got about 20 to 22 questions, which is big number. Rheumatology got approximately 30 questions. And liver gastro alongside with nutrition also together comes to almost like 35 questions, which means that you have almost like 85 to 90 questions coming from these 3 chapters out of the 100 or 150 questions that you have. So that makes it extraordinarily interesting, because whoever has these areas strong, this is basically medicine. I don't think they have dwelled too much into core rheumatology. They've dwelled into core gastro, 1 or 2 questions, but generally if you have a know-how, I think you're pretty safe. Questions that have come from here are far and few. 14 questions from endocrine, which were literally very tough, and majority of them focusing on reproductive endocrinology, which many people may not be well versed with. Cardiology had 12 questions, barring 1 or 2, they were actually speaking very easy. Nephrology was sidelined, completely sidelined, and only 8 questions coming from nephrology, which again is very, very small numbers, and around 10 questions coming from neurology, which again are not proper neurology questions. You can actually say it comes here, there, etc., which means the number of questions that you have from here are just about 44 questions. So what happens is that the tables are completely shifted, or the pendulum is now completely swinging in the favor of these subjects. But will that mean that the same theory will hold true next year also? I'm not sure. It is just that it happened that way. Next year, maybe all the questions may come from here. So this totally is coming to around 130 questions. I told you 7-8 questions came from hematology. Remaining, we had around 12 to 15 questions. These remaining 12 to 15 questions had 3 questions from lungs, 2 questions from critical care, and around 1 to 2 questions or 2 questions or so from oncology. And then there were about general questions based on poisoning and all that, statistics and all that, another 5 to 8 questions or so, which you cannot prepare basically. But still, I thought this time around we'll add a module by emergency medicine people on toxicology per se, because we had 1-2 questions on opium poisoning and all that, which you can answer even without all that. So that is the only thing I wanted to add on, and I request you not to study any statistics, because those questions don't require you to learn. They are very, very, very basic questions for which spending a lot of time is totally unnecessary. So this is how the exam has been. And I feel that if you are a level-headed person who has done your medicine well and studied your medicine well with focus and determination during your 3 years and invested proper time, you don't need any preparation for NEET SS. If you want to do a super specialty course, that's again optional. Then you're writing this exam, and for that exam, you have maybe say 1 or 2 months maybe to just get a grip of the exam, because there is no history for the exam, and that this is the syllabus that you have to follow. So just get a grip of the exam. You can follow a few tests and do the grand test, and then probably start going into the exam. I think that's more than enough, and that is what majority of people have done as well. So there is no hard and fast preparation strategy like what we had years ago, wherein people used to sit and prepare for 3 years, 4 years. Absolutely nothing like that required. It's your medicine that you have to study, and always keep in mind that's the only thing that will hold you in good stead throughout your career. Because once you become a specialist, it's very easy to become a specialist now. Once you become a specialist, then your entire medicine is going to go for a toss. So you need to have that vigor to learn medicine all throughout, and think of a question from a medicine angle, and know that these are the questions which are beyond me. There was a question on cardiac resynchronization therapy. It is not a question that I can take up. I will never take it up also. But those questions will maximum come to 10 or 15. But if I am telling you that, okay, this question on doxorubicin, daunorubicin producing cardiotoxicity, or a myeloma amyloidosis producing restrictive cardiomyopathy with low voltage complexes in the ECG and LVH on the echo is all cardiology, then I am basically an idiot. That is not cardio. That is cardiology, but that is for a medicine person to actually know. It is not for the cardiologist to know. Cardiac resynchronization therapy is for the cardiologist to know. 100% agreed. But you can see how many number of questions were like that. So it is our medicine knowledge that has to help us enable. That has to enable us to kind of tackle this exam and move forward. So let's try to see what this exam had in store. So rheumatology, liver gastro, and infectious diseases, they were the people who stole the show this time, or they were hogging the limelight. Sidelined were cardio, nephro, neuro, and endocrine also to an extent. So duration or strategy? Definitely strategy. There is no duration over here. You can give the exam maybe 3 years after your MD also. That's also perfectly fine. But the duration of preparation that you need to have is not so much. And I am not advocating any one of you to actually straight after your course go for DM. I'm basically saying all of you should take a break. May it be 6 months or 1 year or 1.5 years or 2 years. You have to settle everything. You have to kind of get the tables once again in proper shape, proper order, and then you have to start deciding on what you want to do further, whether you want to do a course, etc., etc. Don't be in a hurry. Just kind of jump over and think that getting into a DM course at 29 years will actually make me successful in life. Absolutely, that's not the mantra. Absolutely not the mantra. It's about you to decide on what you really want in life and prioritize accordingly, and don't once again put the pressure on you, because doing a DM course is not a piece of cake. It's definitely a tough thing. Whether it be an easy course like rheumatology, also there are lots and lots of difficulties once you enter into the course. Just imagine the volumes that you have to study. It's about a disease that you had some kind of an idea as a PG. It's that disease into which you are dwelling. Each and every small thing as far as that particular disease. For example, you say dry eye and dry mouth in something like a Sjogren's syndrome. Once you become a rheumatology PG, you're not an ophthalmologist, but still this dry eye is equal to lipid layer, aqueous layer deficiency. For aqueous layer deficiency, meibomian gland dysfunction. So lipid layer, meibomian gland dysfunction, tear film breakup time. Then we look into the Schirmer test. What is the Schirmer test? How is the Schirmer test done? What is the interpretation of the Schirmer test? Then the stains that are used, the rose Bengal dye. What's the problem with rose Bengal dye? Then this fluorescent test, the lissamine green test. It just keeps going. You know, there are lymphocytes in the gland as far as Sjogren is concerned as a normal person. But when it comes to a rheumatology PG, it's about focal sialadenitis in the minor salivary gland, lymphoepithelial hyperplasia in the major gland like a parotid gland. So things become very complicated. Understood? So it requires a lot of effort. It requires a lot of determination. It requires a lot of thought process. Everything has to actually work in space for us to get the ball rolling. Okay, so learning curves, yes, of course, strategy, notes or videos or questions or combination. Please watch the videos to enhance your overall understanding, and watch the videos very freely when you are a medicine PG. Just see the cases in your ward and accordingly watch, or take it chapter wise and slowly watch. The entry videos are there, which are your medicine videos. Once your entry videos are done, then slowly go into the subject specialty videos based on the topics, and then again always have the high yield content with you. Now this year we're going to come up with something really new, that is your PG content which I have actually designed. I didn't want to change the whole framework and bring out new videos. So we are coming with a new set of videos which are not going to replace your existing videos. No, these are the videos which I feel we just actually labeled as traveling through your residency towards SS. So it will cater to your final exams, it will cater to your ward discussions, and it will cater to your NEET SS exam as well. So that's something that's coming up, and hopefully I think that should settle everything for all time. Okay, overall knowledge is what that matters. And now we are also bringing time into the equation because of this 3-compartment model, 50 questions, 3 compartments, and you basically can't switch compartments. So that is a bit of a pressure because you have to stay with that compartment, and then you have to finish off everything. And once one compartment goes wrong, that kind of hampers your confidence, etc. But I think this confidence and all that is more for people who are, I think, less than 25. Once you're about 25, then you're strong enough to handle it, whatever be the exam. And you cribbing and crying over an exam is just showing lack of maturity. So basically we don't have to do that. You just give the exam to the best possible level that you have and see where the results takes you. So medicine is at the center. This is again what I want to actually tell you. Really have to keep this in mind. Medicine is the strong point. Medicine is our force. Medicine is our subject. We have to be doing justice to medicine. We are all basically medicine people. At the end of the day, whether you are a nephrologist or neurologist, doesn't matter. Finally, whether you are a medicine person or not is the only thing that matters. And what you diagnose may not be actually from your specialty. So there can be numerous diagnoses that way. And rank is not to sit 10 legs. Again, I'm telling you, it's for us to push our career forward depending upon what you want in your career. So it's not like you're sitting on top of the exam and thinking about the exam and thinking again and again, what do I need to do, etc. So that's it. Residency learning curves, utmost important, and reading Harrison versus watching videos is what you need to decide. And I am once again telling you that reading a book which is basically got data which is a little behind is not going to take us where exactly we want, in comparison to people who are the best in their business, who are coming up with the most integral points, the most hardcore points, the core of the subject. And I think if you watch a video of Nishant MR and you try to read MR from Harrison, you will understand what's the difference. And I'm not a person who is for note-based learnings, although because of this big request that you have now actually dispatched the notes, but I'm a person who always wants to get into the core of the topic and see whether I know the core. Okay, streamlining has been done. So now that if you're preparing for NEET SS, you are not looking out to read Palmo, critical care and oncology, but that doesn't mean that you should not be watching those videos. It's not for NEET SS. That's again what I'm telling you. That's a difference of Marrow as a platform for specialty preparation and super specialty exams. That is the main difference. I'm never telling you not to watch Palmo, because when you are a physician, large majority, I would say around 40% of the cases that you see on a given day will have some lung manifestation. And you should be knowing to read an X-ray properly. You should be knowing how to manage pneumonia properly. You should be knowing what's the difference between a bronchitis and a pneumonia. You should know the difference between a bronchopneumonia and a lobar pneumonia. You should know the differences between a viral, a fungal, a bacterial. All that we should be knowing, because day-to-day practice, all this matters a lot. So you should be watching critical care videos, Palmo videos, and oncology videos. I wouldn't recommend everybody to watch, because hemat is the medical part. Oncology only if you're really interested in oncology, because as a general medicine person, I really don't think that you should be knowing a lot of oncology. It is not mandatory. It purely depends upon interest. And let's get ahead from this work-life balance talk and go into work-life integration, because for us, work is medicine, life is also medicine. So you basically have to integrate. You basically cannot think of taking a job. That is where many people are actually caught off guard. They think that, okay, I can do this job and get out of the job and then come back, then have time with the family. Then you are in the wrong place. Absolutely at the wrong place. I don't think this is then meant for you. You should be a person who should be able to have everything together. It's like integration. Every time all this goes alongside with you. It's not like each one is a separate box. Okay. So we are not again dividing these questions into chapters or nothing like that. We are going to discuss all the questions and see as a medicine person where each of these discussions take us to. Okay, we're starting off with a question from liver or gastro, or you can take it as infectious disease, or you can take it as nephrology. So patient is post-transplant and coming with diarrhea, colitis. So diarrhea, colitis, total count is 1800. And they have given that there is a positive blood CMV PCR. So what is that they want you to know? I think I've discussed this under our post-transplant infections as well. We've done a separate module. ID has also discussed this in detail. Just to know that viremia is not equal to tissue invasive disease. Viremia and tissue invasive disease are basically two different things. Here they've talked about viremia, but at the same time they've talked about two symptoms, diarrhea and colitis, and leukopenia and neutropenia is also there in this patient, which means that you are having a tissue invasive disease, which means that this patient is having CMV colitis. A post-transplant diarrhea should make you think of Clostridium difficile, very importantly. It should make you think of CMV colitis, very importantly, and a routine stool culture is also part of the whole process. So you have to be doing this, and once there is a CMV colitis, then there is no point waiting. You can go for valganciclovir, or you can actually go for IV ganciclovir, whichever one is okay. Oral valgan or IV ganciclovir is okay. So starting antivirals is the thing. There is no doubt about it. In case the question, because these are all recall questions, and as Nishant has said, nobody writes the exam to do a recall. So obviously there will be some issue here and there. But whatever said and done, you start antivirals for this patient. In case they have not mentioned a symptomatology, that means just a viremia you are getting. That means routinely we check for CMV and BK viral loads post-transplant. That is just for us to get an idea regarding the intensity of immunosuppression. That means if the loads are very high and the patient is not having any symptoms, that shows that okay, you have to bring down immunosuppression, especially mycophenolate, which is an anti-metabolite. It matters more in renal transplant, because in liver transplant, we don't use any anti-metabolite or anything. They have only one drug, that is tacrolimus. In our case, we have steroid, we have tacrolimus, and we have mycophenolate. And that's the reason why, and we don't have blood levels of mycophenolate. It's only now that we are doing AUC of mycophenolate and taking the trough level and actually finding it out. It's only now that we are having methodology to estimate the AUC under AUC of mycophenolate. So, for a long period of time, we are just going with our gut instinct. So that's the reason why if you are seeing only viremia and no disease, then you can always think about cutting down immunosuppression. But once there is a disease, of course, you have to. Okay, colonoscopy and biopsy is not something that you do routinely. It's only after 2 to 3 weeks if you are not getting any response. And if it is a CMV, tissue invasive disease, and not getting response for 2 to 3 weeks, the patient is unlikely to survive beyond that. So that is question number 1. So just medical knowledge is good enough to answer this. Okay. Now we go to question number 2. In a patient with 2 days of fever and dengue IgM positive after improvement, this is generally what the question is, there is recurrence of fever with pancytopenia. So basically, I think all of you know that we are talking of HLH. HLH is previously called macrophage activation syndrome. We call it as hemophagocytic lymphohistiocytosis. Adult HLH is always secondary HLH. Children can have genetic mutation mediated HLH and all. And when do you think of HLH? Anybody who is having EBV is the most common cause, but like any infection for that matter, where the patient has, especially dengue, we've seen at least 4 or 5 cases I have seen where dengue, the patient is got better, because dengue is a disease where everything happens inside the first 7 days, and after 7 days, the patient starts to get better. And then at a point, suddenly for no reason, there is a recurrence of fever. And then you check the counts and you say the platelets are going rock bottom. You may not be able to figure it out. Then you see the RBC, WBC, then you know pancytopenia it is. Pancytopenia, things are coming down. One simple test, ferritin, you do ferritin be some 4,000, 5,000. You know that it is HLH. So that is basically hemophagocytic lymphohistiocytosis. This is a very simple thing. They have asked the routine list of investigations. So ferritin has to be done, triglycerides have to be done. So bone marrow study is not something that we routinely do, but in case you do a bone marrow study, you can see the hemophagocytosed RBC. So this is basically it, and all the investigations under this have been asked so many number of times. Phagocytosed RBC is the one that you see on the bone marrow. Triglycerides are going to be high, ferritin is going to be high, splenomegaly is going to be there, cytopenia is going to be there, hypofibrinogenemia, this is something that they can actually catch you, hemophagocytosis, ferritin, and low NK cell activity and increased interleukin 2 receptor or CD25. And this has been asked time and again. Just to keep in mind that the secondary HLH is going to be the question. Secondary HLH can be part of infection, EBV being the most common, CMV being the second one, but always keep in mind lymphomas. Whenever you are having a secondary HLH, it is mandatory to do a PET scan, because there could be a lymphoma and rheumatological problems which can actually present with secondary HLH, especially adult onset Still's disease, where about 10% patients can have secondary HLH. Never forget systemic onset juvenile idiopathic arthritis, where patients can actually have HLH, and SLE also, where you can have HLH. So these are the things to be brought to mind. Primary HLH due to these mutations are all generally seen in children only, not seen in adults. So this again, with bare minimum medical knowledge, I think everybody will be able to answer this. They didn't confuse with hypofibrinogenemia, nothing that way. That's the only kind of confusion here, because everything is elevated. NK cell activity is low and fibrinogen levels are low. Those are the only things, two things low. So I think this is also an easy question. Third question, which of the following is not associated with progression of liver disease in HIV? sorry, HCV. So this is a question which I think I have myself discussed so many number of times. That means as far as HCV is concerned, what is the main difference between HBV and HCV? HBV discussion is all about enzyme. HCV discussion, there is nothing called enzyme because enzymes are variable in HCV. Second major point that we kept on discussing was what? In HBV we are talking about HBV DNA low, 20,000 with EAG positive, 2,000 with the EAG negative. In HCV RNA positive, negative. There is no word called titers, and that's why something that has got nothing to do with progression of liver disease is titers. It has got absolutely nothing to do. Okay, HCV RNA load and enzymes have got no value. It's whether you are HCV RNA positive or negative. What is sustained viral remission? At the end of 12 weeks, you are not able to detect anything, or HCV RNA is negative. That is called a sustained viral remission. So basically, you were never looking into this. One more question on HCV was based on the extrahepatic manifestations, and you know that the major extrahepatic manifestations are cryoglobulinemia. I think that was the one asked for the exam. Sjogren's syndrome, porphyria cutanea tarda, cutaneous lichen planus, and membranoproliferative glomerulonephritis. So those are the other associations. So this is also a very easy pick. Okay, if a patient received 3 doses of ARV before exposure and now exposed to rabies, what is the treatment? So this is something which, if you are not connected with your community medicine department, you may actually be in trouble, because many people are not so much in sync with the community medicine department, and if you are not in sync with the community medicine department, you may not actually know this. So prior 3-dose pre-exposure prophylaxis or post-exposure series of more than 4 doses, and where immunocompetent means you need only 2 booster doses. So which means that for this patient who is previously immunized, okay, 3 doses of ARV completed before exposure and now exposed to rabies, and no mention about whether he is immunocompetent or immunocompromised, which means he is immunocompetent, you need only 2 doses, that is 0 and 3 days. Okay, so this is something which I feel we may generally have this tendency to neglect, because we would have studied rabies sometime during our MBBS times and during PG times, unless and until you are in sync with the community medicine department. People who are in sync with the community medicine department would know this 100%. So prior 3 doses pre-exposure prophylaxis series or a prior post-exposure of more than or equal to 4 doses means further you need only 2 booster doses. Okay, and this has been taught very clearly in our ID class, and I think please look into the ID videos. We have new set of ID videos that have come up, and they are really useful as well. Okay, this is not a 100% sure question, but still, a patient recovering from neutropenia post chemotherapy, once again developing high-grade fever, and the patient having abdominal pain. Abdominal pain is the most important thing, and then they have given an image which is almost like this. This is almost like this, and I'm not sure what are the options. But people are having a doubt between, I think, tuberculosis and hepatosplenic candidiasis, and I think something else also. So I am not sure as to what were the other options, but this is a general dictum. This question is definitely pointing towards candidiasis. There is no doubt about it. One, the reason that this patient has multiple microabscesses, tiny hypoattenuating lesions in a patient who is on chemo, and then patient is recovering basically, and then suddenly the patient goes bad. And the biggest clue is the increase in alkaline phosphatase in comparison to the ALT and AST. Alkaline phosphatase is increased disproportionate to ALT and AST. Patient is in that recovering trend, who is actually recovering slowly from neutropenia and then having relentless fever with increase in alkaline phosphatase and abdominal pain. This points to hepatosplenic candidiasis. This is actually a very clear case of hepatosplenic candidiasis. This is a tough question because, first of all, nobody would read hepatosplenic candidiasis. Nobody would have done a module just on hepatosplenic candidiasis. This is a question which is based on whether you have worked, but I don't know what were the exact other options. Were they too tough to confuse you? Because otherwise, if you are pretty clear with this and you know that there are multiple lesions, hypoattenuating lesions are basically equal to candidiasis, and you can see that there are few hyperattenuating things in the middle, which means that increased attenuations which are seen in some of these lesions, and these increased attenuation at the center of some of the lesions actually point towards the pseudohyphae. Yeah, that is basically what is equal to pseudohyphae, and you can see a lesion in the spleen also. This is what is typically called as a hepatosplenic candidiasis, and this is a slightly tough question, but I wouldn't put it as a tough question because I don't know the options. Some of the options, some people I think may have confused it with miliary TB. I don't know what were the other options, but candidiasis exactly presents like this. So, mumps orchitis, this is the other question, which again is a little tricky, but if you watch the ID videos, you can answer this. Mumps orchitis, meningitis unlikely, definitely wrong. I think all of you know that this is equal to pleocytosis everywhere as far as mumps is concerned. But mumps clinical meningitis is not that common. But anyway, I'm pretty much sure that all of you know that meningitis is likely. Then parotitis in mumps lasts for 3 to 12 months. Parotitis at the most lasts for 10 days, nothing more than that. Vaccination provides lifelong immunity. You know, there are so many people who can actually get the disease. Not so many people, but still. And subfertility occurs, I think subfertility occurs or infertility occurs in 30 to 80%. Actually speaking, 30% of unvaccinated people actually develop orchitis. And out of the 30% of unvaccinated people who develop orchitis, 30 to 80% of them have 30 to 50% of them have bilateral testicular atrophy. So 30% of unvaccinated people actually have orchitis. That is the basic point. So neutropenic with subclinical pleocytosis, parotitis results in 10 days. These are the two times where you have to take the vaccine, 12 to 15 months and 4 to 6 years. Orchitis is in 30% of unvaccinated. That's what I told you. 30% of unvaccinated people can have orchitis, and among the vaccinated population is about 1 to 2%. And out of the people who develop orchitis, these numbers are not exactly correct, but around 30% or so can have 30%, 40% can have testicular atrophy. This is what is the data. So this is a question where again I feel that if you don't know exactly this infertility number also, you should be able to come up with the answer, because MMR doesn't give full protection. Everybody knows that. Parotitis is not going to last. You may yourself have experienced mumps as a child. Parotitis is not going to last for 3 to 12 months and all. Absolutely not. And meningitis is unlikely is wrong, because whenever you talk of mumps, we always bring the meningitis also into picture. Clinical scenario denoting malabsorption, biopsy showing PS positive macrophages. I think this would be one of the easiest questions in the whole paper. Whipple, tropical sprue, celiac disease and all that. Basic medical knowledge is more than enough to answer majority of the questions that come. And I've always told you that biopsy is Whipple's, A beta, lipoproteinemia, gamma globulinemia. These are the only 3 conditions in gastro which are diagnosed on a biopsy. And Whipple is almost always the cause. Whipple is almost always the case that they ask for the exam. And about induction, maintenance therapy, about dementia, all those things are important with respect to Whipple. Patient present with fever and GTCS, now unconscious, found to be HIV positive with the CD4 count of only 38. MRI shows 2 ring enhancing lesions in the subcortex with no specific differentiating features. What is the most likely diagnosis? This is another question which people found a little tough. This is actually speaking to be taken very simple, very easy discussion. One option that you are having is with respect to the CD4 count. So one way of looking at it is a CD4 count. CD4 count of less than 100 means you are having basically what all things in mind. Toxoplasmosis, which is correct. Primary CNS lymphoma, which is correct. Tuberculosis can occur at any CD4 count. So you basically can't say that way. Ring enhancing lesions in the subcortex, which means if you look into the images, I'll just show you the images to understand this better. This is kind of subependymal in location. See, this is subependymal in location. It is more diffuse in location, and this is ring enhancing with no hemorrhage prior to treatment, and spectroscopy is different. This is how a primary CNS lymphoma will look like. Whereas if you look at a toxoplasmosis, why I say this is toxoplasmosis, because of 4 or 5 reasons. One reason that I can tell you is that there is ring enhancement. Second reason is that it is periventricular in location and basically subcortex, basal ganglia, internal capsule. That is where you have all the lesions. You can see here. See, more hyperintense lesions in bilateral basal ganglia and subcortical white matter with significant perilesional edemas. And after giving cotrimoxazole, you can actually see how much a difference there has been. And look on the other hand, how a lesion which is a primary CNS lymphoma looks like. So it's more of a solitary lesion. It is not a ventricular lesion, and it is not a basal ganglia lesion. And more than that, this is more, focal with no hemorrhage. The other one can have hemorrhage. So the only doubt you basically can think of is a person who is having a primary CNS lymphoma presenting this way. But I think primary CNS lymphoma means I think this wouldn't have been the whole thing. And they would be talking about more irregular lesion. They'll be talking about a more heterogeneous lesion. They'll be talking about more of a periventricular location. They'll be talking about memory loss, hemiparesis and all that. So this is for all practical purposes equal to toxoplasmosis. Tuberculosis, again, very unlikely to present this way. Tuberculosis per se will be a solitary lesion most of the time, and cortical is going to be the location, or deep gray matter is going to be the location, and you may get sometimes the target sign, but target sign is not specific, but some kind of a calcification, especially central calcification, all those things are more likely. So Although this is a slightly tough question, if you apply yourself and see the counts are low, so I think they are looking for either CNS lymphoma or they are looking for toxo. Patient has become unconscious, which means very rapid progression. That is very much in favor of toxo. 2 ring enhancing lesions, again more in favor of toxo. Subcortex very much in favor of toxo with no specific differentiating features. So out of this, it looks more like toxo. I don't know whether this was the exact question. People had confusion between toxoplasma and CNS lymphoma. I think this is more likely in favor of toxo. Okay, this is how the tuberculoma looks like. It's like, actually speaking, in the deep gray matter, or it's a cortical thing more than anything else. Liver abscess, drug of choice. Liver abscess drug of choice is basically another question where people can go wrong as to whether they are dealing with amoebic abscess or a pyogenic abscess. I don't know what kind of the image was given. If it is a pyogenic, you will be seeing multiple lesions on either lobe of the liver. If it is amoebic, you will be seeing one single thing. And if it is a pyogenic, obviously you have to go for IV antibiotics and drainage. And if it is amoebic, then of course metronidazole. Out of the question that was actually mentioned, I think it was a solitary abscess, and more common is amoebic abscess. So with that logic, I think probably they wanted the answer as metronidazole. This is what I suppose. They have not given more details. This kind of a question is just the gut instinct and your luck on that given day. We can't prepare for this kind of a thing. Okay. Amoebic abscess, drainage is not routinely required. You do drainage if the cyst is more than 10 centimeters, imminent risk of rupture, or there is a clinical deterioration. Okay, and generally percutaneous drainage is what is done for a pyogenic abscess which is more than 5 centimeters. You need not actually go for drainage in all the cases. Needle aspiration can be tried in less than 5 centimeters, or catheter placement can be tried for less than 5 centimeters. There is no hard and fast rule that way, and this is more of a higher end gastro thing. But generally, to know about a liver abscess is mandatory for a medicine person, and he knows that amoebic is more common, single lesion is more amoebic, that requires therapy, and that is equal to metronidazole. That's more than enough. And generally, we don't go for any kind of routine drainage unless and until the cyst is more than 10 centimeters or there is an imminent risk of rupture. Okay. Why is understanding of pharmacokin? This I think I've explained so many number of times. What is called concentration dependent killing and time dependent killing. Because of concentration dependent killing, always give these aminoglycosides once daily, because it is a concentration that you achieve that is at most important. That's why I told you gentamicin 80 mg BD dose is very wrong. Levofloxacin, ciprofloxacin, gentamicin, amikacin. Always give once daily. Even ceftriaxone 1 gram IVBD is a wrong dosage. It acts by concentration dependent killing. So please give it 2 gram IV OD. I have told this so many number of times. Whereas cefotaxime acts by time dependent killing. Almost all the penicillins and cephalosporins act by time dependent killing. So you can actually give it as many number of times as you want, even 4 times, 5 times. Reiter syndrome, arthritis, conjunctivitis, had flu 2 to 3 weeks, causative organism. This I think we've discussed so many number of times. And the table also has been highlighted so many number of times. And I've told you that chlamydia trachomatis is the most common organism worldwide. Shigella flexneri is the most common cause of reactive arthritis in India. Shigella, Salmonella, Yersinia, Campylobacter, all these things are very common. E. coli is notoriously lacking. Then we talked about the other organisms which are associated, like your chlamydia trachomatis, ureaplasma, urealytic venom. We had an extensive discussion. Simple, everybody knows this. The answer is Shigella. And Keratoderma blendragica was another question, which of course is very easy. Keratoderma blendragica, circinate balanitis, and all. We've had extensive discussions under our chapter on spondyloarthritis. So this is the most common cause worldwide. Shigella flexneri is the most common cause in India. And other things are chlamydia pneumoniae and ureaplasma urealyticum. So this is about it. Child with sore throat and fever and tongue numbness and all that. It's a simple question on diphtheria. I don't think there is any kind of a tough thing with respect to that. Another question is nosocomial pneumonia. This is slightly tough. MRSA with a platelet count of 40,000 and MIC 1.5. This is the real tough question inside this. This is a question which I myself don't know the answer. I'm not sure about it, because people generally say that if the MIC is less than 2, you can use vancomycin, and if it is between 1.5 to 2, you can generally give rifampicin also with that, and that way the answer can be correct. But there are a lot of papers showing that ceftaroline is the drug to go because it is of use in MRSA, and this is the new drug, the new kid on the block, etc., etc. So basically, either they would have wanted you to know that because MIC is 1.5, it is between 1.5 to 2, you can add rifampicin and make vancomycin work better, or they want to know that the new drug for MRSA is ceftaroline, and ceftaroline is of great value. Both are actually correct options, but because ceftaroline is new on the block, probably they wanted you to know that. This is again a kind of a question which you can't prepare and go for. This is just luck, nothing else. So questions are tough, but then we always have the leverage of getting 25 questions wrong, which is pretty much okay. Stavridin, simple question. I think Stavridin is not used by anybody, but that Stavridin would be grateful for the board for remembering the drug. It's not part of any regime that I know, but we have studied during MBBS so many number of times. Peripheral neuropathy and lactic acidosis combination with hepatic steatosis is Stavridin. Now, even if you don't know that, myelopathy, of course, is not going to be coming like this. It is a human thing. And neuromuscular disorder is going to have fatigability, ptosis and all that. So that's also out. Some people were talking about HIV neuropathy. We very clearly mentioned HIV neuropathy is a distal symmetrical sensory motor polyneuropathy. It's not a large fiber thing. Large fiber thing, motor weakness, hepatomegaly, lactic acidosis. I think all of you would have got the answer. It's a Stavridin neuropathy. Okay. Bacterial meningitis, I think everybody knows. Empirical therapy for bacterial meningitis is equal to penicillin, that is your ceftriaxone. And with that is again 2 gram IV BD with vancomycin, because you are going to cover for penicillin resistant streptococcus pneumoniae, and either of ages, especially above 50 and very small children, cover for listeria, and listeria is with ampicillin. And understand that listeria are intrinsically resistant to cephalosporins, so there is no point in giving cephalosporins in listeria. So this combination of ampicillin, vancomycin and ceftriaxone is going to serve the purpose. It's an easy question. Everybody got the question right as well. Rifampicin resistance, I think I myself know that RPOB is the problem. So RPOB is the thing. But when it comes to RPOB, again, you may have a doubt with respect to whether it is an activating enzyme, inactivating enzyme, alter target enzyme. RPOB is the typical example for an altered target enzyme. Activating, it's not an activating enzyme, it is not an inactivating enzyme. Activating enzyme based resistance is different. You get it in nitrofuran and all that. Inactivating based enzyme resistance is also different. Efflux is also different. So this is again a tough question because it's a pharmacology question. It's not a medicine question. We have one table in Harrison which is telling you all this and nobody can study the table. So there's no point in going and studying that table. But tomorrow some other question may come, somewhere else it may come. But RPOB mutation, you know, is basically a drug enzyme. So that way, maybe you can guess it out. So RNA polymerase is the enzyme, RPOB is the mutation, and that is why the answer here is altered target enzyme. Some of the people got it right, few people thought too much and got it wrong. Leishmania gold standard, I think everybody knows. It is bone marrow biopsy to actually demonstrate the masticode. You are always in a better space to study malaria, leishmania. So I have done a small synopsis on tropical infections under medicine, but up and above that are also HIV. Up and above that, all the basic infections under each of the chapters are covered, like pneumonia, infective endocarditis, or meningitis. That's been covered. So all those are mandatory to know. But up and above that, I think 1-2 special videos, MCQ discussions of your ID faculty is also, I think, warranted as far as the exam is concerned. I think Ankit has come up with some really good videos also of late, and they're really good. So if you can actually watch to enhance your knowledge with respect to that. Pregnant woman showing asymptomatic bacteriuria in the first trimester, identify the correct approach. You have told this n number of times. Asymptomatic bacteriuria, then and there you have to screen, and then and there you have to treat in people who are pregnant and undergoing urological procedures. No more discussion, nothing else. Screen and treat in pregnant females and people undergoing urological procedures. And recent transplant recipient, that's a bit of a plus or minus thing. These are the two ultimate options where you have to definitely treat asymptomatic bacteriuria. Recent transplant recipient is more of clinical discussion. Okay. Now, and what do you give? Penicillins are generally considered to be the safest. Okay, they are the safest. This was another question which had lots of debate. Diverticulitis, what should you do? Should you give drainage first or you give antibiotics first? It's a really tough question. You can watch how Rizwan has discussed about diverticulitis. It's a core gastro question. These are the so-called real tough questions, which obviously a medicine person can't answer, because diverticulitis itself to me is surgery. I'm basically thinking that I need not know liver abscess, I need not know diverticulitis, I need not know cholecystitis. I'm thinking all this is surgery. But once I become a gastroenterologist, then I understand that, okay, I have to be learning this also, because this is now medicine. Like, for example, if it's a medicine person, you are asking me about PCOS, and I'll say it's got nothing to do with me, please go to the gynecologist. But suddenly one day I become endocrinologist and I have to know about PCOS. There is no way that I can't know. So the same thing applies here also. If I were the student for the exam, I would always write antibiotics, because there is no way that you can manage anything without antibiotics. So that's just a layman's way of writing it. But there are so many more things with respect to diverticulitis, and I personally feel that the answer should be antibiotics, but you can always argue. Most common organism in febrile neutropenia leading to sepsis. Febrile neutropenia is an extremely important topic, extremely important discussion, which we've done under malignancy. Also, this becomes really important in people who are undergoing chemotherapy for leukemias, and also people who are awaiting engraftment after transplant, especially AML, ALL. In this setting, you know that once you complete your chemo, it takes about 10 to 14 days for the counts to recover. And by 8th day, 9th day, 10th day, patient's total count is 50, 75, 100. So day in and day out, you have to watch the patient for subtle signs. It may not be a fever. It may be just a tremor. It may be just a shivering. It may be just a tachycardia. And the patient may throw fever. And if you're not able to give the first dose of antibiotic within 1 hour of onset, then the mortality rates are going to touch 80%. So how dangerous febrile neutropenia is. And I think all of you worked in wards, you'll know what is the importance of febrile neutropenia. Febrile neutropenia is more commonly produced by gram-positive organisms because it is loss of mucosal integrity, GI mucosal integrity, that is a leading cause for febrile neutropenia. Although you have to be very wary of the catheter, catheter-related infection, the urinary catheter. The other catheter I talked is the PICC, okay, peripheral inserted central catheter, then the urinary catheter, then your simple line, anything and everything. You have to be looking into oral cavity, all that is there, but generally only around 10 to 20% cases of febrile neutropenia we are able to even identify an organism. And in that case, the more common organisms are gram-positive organisms. But remember, febrile neutropenia is a real cause for concern because we get MDR gram-negative. And once we get MDR gram-negative, then we are in trouble. So febrile neutropenia leading to sepsis is always MDR gram-negative, and in that, the main chief villain is Pseudomonas. Okay, this I have discussed alongside with chemotherapy and treatment part in our AML, ALL, as well as the videos which are basically based on hematological malignancies. But otherwise also, I think as a medicine person, all of you will be knowing this. So this is not at all a good question because there are so many antibiotic regimes approved and it is based on the hospital setting where you're working. Meropenem 1 gram IV TDS is 100% fine. That's perfectly okay for a febrile neutropenia patient. Piptas is 100% okay. 4.5 gram IV Q6H is 100% okay. Cefepime 2 gram IV TDS is 100% okay. All these things are okay. And the recommendation is if you're having a hypotension or you're having a pneumonia like kind of a setting, you can add gentamicin. There is no harm. If you're suspecting a gram positive due to a skin infection, soft tissue infection, catheter infection, then you can always use vancomycin. So both these options are actually correct. Meropenem is correct. Piptas with gentamicin is also correct. I don't know what the hell they are looking for. Maybe because they added gentamicin in that option. I don't know if you are looking for pneumonia or hypotension. If that is there, there is a recommendation to add aminoglycoside. Otherwise, meropenem 1 gram IV TDS or Piptas 4.5 gram IV Q6H. Both are correct answers. So it really is up to the examiner and our luck to see what is right or wrong in this. Pregnancy with the JC virus reactivation was one question I got. I don't know whether it is right or wrong, but natalizumab is notorious for reactivation. I think Bashik has taught so many number of times. Everybody knows about natalizumab. Natalizumab in the context of Crohn's and ulcerative colitis, I have taught you, and there I have told you about JC virus reactivation. Another version to the question is relapsing remitting multiple sclerosis patient is there who is basically pregnant and you have to treat. So when you are treating a pregnant female with relapsing remitting very active disease, Lermit sign and all positive, what is your option? So then your option is glatiramer acetate and natalizumab. Here the JC virus titers are low, glatiramer acetate is not there in the option, you can always write natalizumab. So that way is also correct. So I don't know which is the right question or where there were two questions like this, but again, this is something which we expect most of the people to get it right. Hepatitis E and acute fulminant hepatitis, I think that single point you need to know, that is like 0.1 to 1%, and that suddenly becomes 20% in pregnancy. That's the risk of fulminant hepatic failure or acute liver failure. That's just depending on the duration. So ALF is more in pregnancy than non-pregnant, 100%. More severe in the first trimester than third trimester, definitely not. The cases that I have told you are all mostly second trimester, third trimester cases. Chronic liver disease in AE is unheard of at MD level. DM level, they will say genotype C and all, but MD level, E doesn't cause chronicity. Most common cause of ALF worldwide or in India, I am not sure about the option. But anyway, the second option is the right option. Most common cause of acute hepatitis in our country in children is A and in adults is E. That is acute hepatitis. That is not equal to acute liver failure. Acute liver failure can have so many causes. E causing liver failure outside pregnancy is very, very rare. So that is paracetamol toxicity and all that we have discussed separately. But whatever said and done, if you have a know-how of this particular option, then there is nothing else that you need to be knowing. Most common cause of acute liver failure in adults in our country is basically hepatitis E. I agree with that. And paracetamol is now like almost equal status, but till textbook says E in India and paracetamol elsewhere. But here I think they've said worldwide, where it is definitely not E, it's paracetamol. But whatever said and done, I wouldn't even read the other options. The other options are totally insignificant because ALF is generally associated with much higher ILF and much higher mortality in pregnancy than non-pregnant state. Okay. Unconjugated bilirubin, raised rest, everything is normal. It's a Gilbert question, which I think will be a cakewalk. So absolute contraindication liver transplant. I don't know why people got confused in this question. I am not sure whether these are the exact options, but active sepsis, active malignancy, and active substance abuse is definitely a contraindication. It's an absolute contraindication, whatever said and done. And urine ethylene glycol, ethylene glucuride positive is basically equal to active disease. So severe cardiac and pulmonary disease with severe pulmonary hypertension, alcohol addiction, hepatocellular carcinoma with extrahepatic means current extrahepatic malignancy, and sepsis. These are the absolute contraindication. Here they've talked about active alcohol use, and that is why urine is positive. So I'm not sure whether that's a tough question, but some people said that was tough. Maybe the options are not exactly correct. I'm not sure. Wilson's disease gold standard is what they asked. Liver biopsy, hepatic copper content. I mean, just like exactly like that. I think it's an MBBS level question. Raised bilirubin, normal enzyme. You want to do biopsy and find out the cause for liver disease. INR is 1.8. Naturally, you can't do the normal biopsy. You will go for the transtubular biopsy. And again, very basic, very simple question. A patient with ulcerative colitis present. So this is an interesting question because if given high ALP, that is cholestasis, USG normal, intrahepatic cholestasis. Intrahepatic cholestasis, the first set of things that come to mind, sepsis, PBC, PSC, sarcod, everything comes to mind. Then they have given this heading that ulcerative colitis is already there in the patient. So when ulcerative colitis is already there in the patient means ulcerative colitis association is obviously primary sclerosing cholangitis, which is now considered to be an IgG4 related disease, and the antibody is P and K. Very simple. No doubt, PBC, AMA, and your P and K is what we see in primary sclerosing cholangitis. Okay, AMA positivity indicates PBC, PSC, and PBC we have discussed 100 times. Yeah. Drug to be added, so primary biliary cirrhosis now called primary biliary cholangitis. Drug to be added to steroid for autoimmune hepatitis is of course azathioprine. Steroid azathioprine is the basic mainstay of therapy as far as autoimmune hepatitis is concerned. It's not like to be added. It is steroid and azathioprine, and we've discussed about that. That's a big score and all. Score and all is not required, but to think about whom to be treating, that's also a very important question. We have discussed that whom to be treating if you get an asymptomatic patient, whether to treat or not. Those considerations, Tarun has gone into detail, but even basic stuff I have actually told you, and that's good enough to answer this. Hepatitis C and cryo, again I told you, routine anti-HCV positive. What will you do in a patient? Of course, there is no value for routine anti-HCV positive. You always have to go for HCV RNA. This is a simple question which I think some of the students unfortunately got it wrong. I don't know why they went wrong, because when you donate blood, what's the next step? What's the bloody role of knowing your HBV DNA loads when you're donating blood? That is a treat. You are basically wanting to know whether you're having chronic hepatitis B or not. So basically, what do you want to know? You have to go for anti-HBC, total and IgG, or total and IgM, because anti-HBC is what you have to know whether you are chronic hepatitis B or not. Because when you are HBsAg positive, one thing, you can be false positive. Second, you can be in the early phase of acute hepatitis where you will be anti-HBC IgM positive, or most likely you will be a chronic hepatitis B where you are anti-HBC IgG positive. Without knowing that what point, so you have to be looking for anti-HBC IgG. I told you about the need for checking for anti-HBC IgG in people who are actually even planning to donate blood without looking for HBsAg, and again to check for this in people who are going for dialysis, going for a transplant. All that we have discussed. It's a simple question. Undergoing phlebotomy once in 2 weeks has a hemoglobin fall from 18 to 14. Okay, what is the next step? This is a practical question. Nobody can teach you this. So you are doing phlebotomy for hemochromatosis, and hemochromatosis, they have not given the TSAT value or ferritin value or anything like that. Once it has come to 14, will you stop? No, there is no point stopping. Can you do once in 2 weeks, but it has come to 14, you may want to reduce the frequency. That is what generally we do, and then keep a check on our ferritin and accordingly decide, and then make it once a week. So if I were to answer this, I will write it as once a week now, because once in 2 weeks it's going well, it's come to 14, 18 to 14, so we can actually make it once a week, and then based on ferritin we can actually change it. So whether you will continue with once in 2 weeks and then do ferritin and make it once a week, or you can straight away now make it once a week and continue, is a purely hepatologist decision. It depends upon so many other parameters. But looking at the framework of this particular question, I would say that over a period of time, it has come from 18 to 14. So because it has come from 18 to 14, it's now going once in 2 weeks. You can taper it down to once a week. I think that is the answer. I'm not exactly sure. C2A2I negative. Still, you have to go for non-HIFE, and I've talked about juvenile hemochromatosis, the genes that are involved in non-HIFE, and your hepcidin, and the importance of cardiac involvement in non-HIFE and all that. So that's a very easy question. C2A2I negative means that is HIFE negative. or hemochromatosis which is not a classical hemochromatosis or the adult hemochromatosis, you have to think of juvenile hemochromatosis which is TFR2, hepcidin and all that, hemojuvelin and all that. Okay. HCC 5 centimeter treatment, again tough question. Again, we don't know exactly what are they looking for, because because anyway surgery is not an option, transplant is not an option, sorafenib is not an option. I think they may basically have wanted taste, but again I am not 100% sure about it. Okay, not 100% sure, but thinking that taste is so popular, transcutaneous arterial chemoembolization is so popular, I think probably they may have wanted that. But Tarun has discussed this question in detail. We didn't get enough data on the question. So because of the fact that we didn't get enough data on the question, I always feel that they may have looked for taste, but the exact question we couldn't get. Binge alcohol consumption with altered sensorium and psychotic features will respond to IV fluids and thiamine. This was a very simple, straightforward question once again. Cells remodeled in liver disease to produce fibrosis is your stellate cells. Next best test for a patient found to have a lesion on liver on ultrasound is always your triple phase CT. Post-intestinal resection, patient having ataxia, peripheral neuropathy is always vitamin E deficiency. Polycythemia rubra vera with Budd-Chiari syndrome, next investigation is your first investigation, that is always your Doppler. Okay. Finally, bleeding gums, vitamin C, polished rice, heart failure, B1, angular cheilitis and glossitis, B2. TP and refeeding syndrome, will come to the exact question a little later. I don't know why people got confused with that. They were saying that there was altered sensorium. Hypophosphatemia can produce metabolic encephalopathy. Phosphorus is required for growth, RBC, bone, as well as for muscle and cardiac. So all these things can get affected, but if the phosphate levels come down to less than 0.5, there can be metabolic encephalopathy. Also, on top of that, there is magnesium low as well. So even that can actually contribute, but it is hypophosphatemia. That's the reason for everything else. Okay, so this is another question where again, exact question, I'm not sure what's the question, but every gastric ulcer, of course, you need follow biopsy. It's not like a duodenal ulcer. Every gastric ulcer, you have to go for your biopsy urease test, and then you have to save for H. pylori, and then H. pylori eradication is mandatory. After H. pylori eradication, to go for a rebiopsy, all this is done. So, I mean, based on the wordings of the question, things can change, but the essential core concepts are the same. So, I think follow-up endoscopy is recommended, document healing, rule out malignancy, and establish your H. pylori eradication. So, hopefully something like that was asked. D-xylose test, there is low D-xylose. I think all of you should have got this right. D-xylose is actually a carbohydrate which is absorbed from the proximal small intestine, and it requires an intact proximal small intestinal mucosa. If there is some integrity issue with respect to the proximal small intestinal mucosa, then you will not be able to absorb D-xylose, and hence D-xylose will not come into blood, D-xylose will not come into urine. This is called a positive D-xylose test. So what are the cases where you can get a D-xylose test positive? Any disease which affects the proximal small intestinal mucosal integrity, like a Whipple, like a celiac, whatever. Now, you can additionally get D-xylose positive, false positive, when xylose is being destroyed by the organism which is migrating from the large intestine to the small intestine, that is called SIBO, when you are having vomiting, or when you are having rapid intestinal transit, or when you are having ascites, or when you are having renal failure. These are the causes for a false positive, actually speaking, D-xylose test. So, in this case, this is a clear case of bacterial overgrowth, what we call as SIBO. SIBO is causing the bacteria to migrate from the large intestine to the small intestine using up D-xylose. So, D-xylose is not absorbed. Very simple, very easy question. You should be getting it right. I have discussed the test myself, although practically right now it's not done. Least likely to cause chronic pancreatitis. Again, I think all of you know this chronic pancreatitis causes and all. Everybody knows this is the famous Tigaro causes, and I feel nobody would have got this question wrong. Patient with painful chronic pancreatitis undergoes treatment. This, I think, if you've studied the pancreatitis module, I think this one has mentioned this so many number of times, that you can get a orthostatic hypotension as a key complication of a celiac ganglion block. But even if you have not studied this, I don't know, pregabalin endoscopy and those things can never produce a postal hypotension. So probably even without that, many people got the question wrong, got the question right. Acute cholangitis having a suspected stone, the basic principles. That means MRCP is your investigative modality and ERCP is your therapeutic modality. If there is a stone and cholangitis, then there is no point in doing MRCP. That is only about therapeutics, and therapeutics is with ERCP. Again, very easy question that. Abdominal distension, jaundice, and diagnose CLD, non-bleeding varices. What is the drug of choice? Carvedilol or propranolol as usual. You know HPPG and how we calculate HPPG and what we put the patient on as prophylaxis. It's a very easy question. Carvedilol or propranolol. Celiac disease antibody with the highest negative predictive value. Just to tell you that sensitivity is A by A plus C, and when sensitivity is high, negative predictive value is high. So highest sensitivity will be equal to highest negative predictive value, and IgA anti-TG has the highest sensitivity, and that's why it has the highest negative predictive value. Diverticulitis question we've already seen. It's a little doubtful. So consider CT scan to confirm diagnosis and rule out alternate. Use antibiotics selectively. This is what is actually mentioned. So, but still again, little tricky kind of a question. Ulcerative colitis, the same thing I have actually told you. Mesalazine they've started, and then the patient has to, anybody who has ulcerative colitis then coming with a bloody diarrhea, first thing that we do is to take a stool culture, rule out infection, especially Clostridium difficile. Then only we think about relapse. And if there is a relapse, then we look for other extra manifestations of ulcerative colitis, which are your extra intestinal manifestations, which are always in sync, like an arthritis or an episcleritis or an erythema nodosum, something like that. So this is stool sample for infection. Next step in a patient with large gastric varices. This is a real tough question. This is a proper gastro question. And I think Rizwan has done a discussion on that. You can watch that as well. But my two pieces of advice with this, gastric varices and esophageal varices have nothing to do with each other. Gastric varices are like an iceberg. That means you are seeing only the tip of the iceberg. And HVPG and the values and those rules are not applicable for gastric varices. And gastric varices are nowadays managed by the interventional radiologist with some techniques like BRTO, Practo and all that, which I am basically not the person to tell you. And I also don't have much idea about that. So in the meanwhile, first management for a gastric varice is always glue injection, no doubt. And then you stabilize the patient and go for a TIPS. That is generally what is advised. But here TIPS is not there. Balloon tamponade may hold the patient for 24 to 48 hours. So glue injection and to hold the patient for 24 to 48 hours, probably you can use balloon. So that is probably, I think, the answer. But again, this is a very higher order question. Patient has completed H. pylori, stop PPA and test after 2 weeks. I think this is something which I have told you. You need not do endoscopy to confirm eradication. Stool eradication test is more than enough. After 4 weeks of completing therapy or minimum 2 weeks after PPA, you can always do the test. This we have discussed so many number of times. Okay. 30-year-old female with secondary amenorrhea has FSH of 27 IU per liter. What is a likely mutation in this patient? This is a tough question. I am also not sure what they are actually checking for. I personally feel that they have given as per 2 students who've told me that the patient has autoimmune thyroid disease. If autoimmune thyroid disease is there, you can jump and mark the answer as AIRE because this is polyglandular autoimmune syndrome or autoimmune polyendocrine syndrome type 1, wherein you are having hypogonadism, premature menopause. Okay, so premature ovarian failure. So that can actually be there. If nothing else is there, then probably you may have to mark it as FMR because FMR can actually produce a primary ovarian failure with high FSS. That is possible, but I still feel the answer is AIRE because many of the students were of the opinion that some autoimmune features were there. And you know that as far as PGA or APS1 is concerned, hypoparathyroidism, thyroid disease which can be Graves or Hashimoto, of which commonly it is actually Graves, then type 1 diabetes, Addison and hypogonadism. These are the 5 things, out of which anything can be there. So it's a tough question. I mean, if you are having the other autoimmune manifestations, I think all of you will write AIRE or else you write it as FMR. Okay, that's it. Then episodic palpitation, hypertension attacks. It's a good question. I think I have not taught you this question exactly the same, but I have told you very clearly that norepinephrine is being produced by the extraadrenal fluos because the PNMT enzyme is absent, so they cannot convert norepinephrine to metanephrine. So it's very easy. So that way you can always say that extraadrenal is the one that they may be asking for, but then suddenly they have come up with the genetic causes which are responsible for your MEN syndrome, for your pheochromocytoma. NF1 is there, MEN is there, VHL is there, all that is there. So from here, one way is that you know that VHL produces norepinephrine, everything else produces metanephrine, which I don't think anybody would know. But this point about ataxia, cerebellar hemangioblastoma, von Hippel-Lindau syndrome, ataxia with pheochromocytoma is von Hippel-Lindau. It's a very simple thing. If you know that the key cardinal feature of your von Hippel-Lindau disease is basically equal to clear cell carcinoma and then your cerebellar hemangioblastoma, then I think you'll be able to get away with the answer. I think most of the people got the answer right as well. Longest half-life. Tough question. This is not tough because see, I also don't know the exact half-life of FSH, LH and TSH, but I know 100% that HCG has got a half-life which is much more than FSH, LH and TSH. That is what I know. So it's not like I know the exact half-life, but HCG definitely, because FSH, LH and TSH would have half-lives in the range of hours, but HCG would have a half-life in the range of days. So basically with that, you can mark it as HCG, but whenever we discuss a particular hormone, there we talk about half-life, but we have not discussed the entire half-lives and all, which I don't think is required also. If you have that idea, you can mark the answer. You don't have to know all the half-lives to answer this. 3 months polyuria, serum osmolality 280, urine osmolality 300, serum sodium 140, nocturnal polyuria absent. It's a slightly tough question because when the urine osmolality is 300, we are thinking of a water deprivation test to differentiate between central DI, nephrogenic DI and polydipsia. And primary polydipsia can be psychogenic or otherwise also. So those are 3 things. But when they specifically mention that nocturnal polyuria is absent, DI has to go out of your mind. That is what I think the examiner wants, because DI patient will drink water from everywhere. He will drink water from the closet also. He can't stop himself from drinking water. The catch feature of DI itself is nocturnal awakenings, cold water, drinking. So that's basically how it's described in the textbook. But psychogenic people can also drink. I'm not saying no. But when they give this data for your exam, then central and nephrogenic DI will go out, and because of that you may write the answer as polydipsia. Serum sodium has nothing much to do in this question. Hypernatremia is not seen in DI. It's like sodium will be on the slightly on the higher side, but you'll be drinking water to maintain sodium in that range. It will never go to hypernatremia unless and you will stop drinking water, which you cannot. So because of that, I probably feel that's the way it is. This is a module on congenital adrenal hyperplasia that I've done, where I have drawn everything and shown you everything. Even without knowing anything, you know that hypertension is 17 and 11. 11 is like 21, which is female pseudohermaphroditism. 17 is like male pseudohermaphroditism. So male with ambiguous genitalia is male pseudohermaphroditism. With hypertension is always 17 hydroxylase, which is MBBS level question. I think majority got it right. Patient with Cushing's, this is a tough question. Patient with Cushing's disease underwent bilateral adrenalectomy and presented after 10 years with hyperpigmentation. What is false? So, this is Nelson syndrome. All of you know, post-adrenalectomy, you can have an ACTH secreting adenoma, which is big. And I think from what I have taught you, if you think clearly, you will get the answer. Cushing's disease, I don't know who is doing bilateral adrenalectomy. Maybe some rare indication or something like extensive disease and very bad disease, and you may have to do. Otherwise, I don't think anybody does. But suppose you do, because Cushing's disease is a pituitary, then you have to do a pituitary surgery for that. So once you do bilateral adrenalectomy, there are 2 points which are always mentioned. And even in the standard clinical endocrine books, they always tell about 2 things. One is that this ACTH tumor is actually speaking of big tumor, and it produces a lot of mass effect and stuff. That is one thing they tell you. Second thing that they tell you is that, and because the ACTH levels are skyrocketing also. Second thing that they tell you is that it produces hyperpigmentation. That's why it's the combo of hyperpigmentation, big tumor, mass effects, and ACTH. That is called Nelson syndrome. So visual disturbance seen is 100% correct. Octreotide is not useful. I am not thinking that it's surgery what is required, and pasireotide may be tried. That is what we know. ACTH levels in the disease is much less than routine adenomas. That is definitely wrong. ACTH levels in the disease is very high. Central hypothyroidism not seen. Stalk effect mediated central hypothyroidism may be seen, may not be seen, but not very significant. So I think this answer is definitely correct. I mean, definitely wrong. ACTH levels in the disease is much less, means ACTH levels in the disease is much higher. Fatigue, again, I'm not sure about the exact question. Fatigue, weight loss, polyuria, low sodium, low cortisol, joint pain, calcium normal, ESR normal, TSH normal. So fatigue, weight loss, polyuria with a low sodium, low cortisol. So probably you're looking at a central, acquired hypopit. So in a hypopit, is it equal to pituitary adenoma producing hypopituitarism, or METs producing hypopituitarism, or is it sarcoidosis producing hypopituitarism? See, actually METs produces a posterior pituitary issue. So it's going to produce solely posterior pituitary problems, not like anterior and posterior pituitary issues. So it's between pituitary adenoma and sarcoidosis. A large pituitary adenoma can actually produce this. Yes, it can produce this by stalk effect. But the problem is, where will you account the joint pain? You can't account the joint pain. Second is, how will you actually account for so much of polyuria? Because so much of polyuria meaning that the posterior pituitary is involved very badly. So when posterior pituitary is actually involved very badly, it means that there should be something inside itself. That cannot be a compression from outside. Compression from outside can also produce posterior pituitary issues, but infiltration would be the better answer. And joint pain is also there, meaning that I will write sarcoidosis. Probably they want you to know that only 10-20% of sarcoid has hypercalcemia. Rest of them have normal calcium. So you basically can think of sarcoid in this question. Although very close fight between pituitary malignancy, adenoma, I mean non-functional pituitary tumor, and sarcoid. But I think with joint pain is there, that goes in favor of sarcoid. Weight loss again goes in favor of sarcoid, because pituitary adenomas are generally speaking not malignant, so they won't produce weight loss. Fatigue is very non-specific. Polyuria is again seen in both, but because IgG4, sarcoid are central lesions, they can produce more of stalk issues and produce more of polyuria. Okay, tough question, but I still feel sarcoid. Female with cyclical abdominal pain, diabetes at 10 years, CKD at 18 years, uterine malformations, we've discussed so many number of times. HNF1 beta, MODY 5, and the manifestations associated with MODY 1, 2, 3, 4, 5, everything very clearly mentioned. And kidney disease is there, diabetes is there, renal cyst is there, all that. So I think that's an easy question. Then oxcarbamazepine and hyponatremia due to SIADH, yes, very clear question. 17 years having optic atrophy, short stature, amenorrhea. This is a question which I am not sure exactly as to what they are looking for in this particular question, because 17 years optic atrophy, short stature, amenorrhea, probably they can actually think of one, that is septoptic dysplasia, HSX1 mutation. If that is there, you can think that way. Or you can actually think of a big non-functional tumor going and hitting on the stalk, and non-functional tumor hitting on the stalk associated with so many of the features of that particular tumor, etc. And the patient can have visual field defects because of that, and that can later lead to optic atrophy. So that way a craniopharyngioma can also be a correct answer for this question. So it's a tough question, but if you see craniopharyngioma, adolescent age group, big tumor going and hitting on the stalk, producing panhypopit is possible. So that way that can be the answer. Child with Noonan syndrome, I don't know. I basically have only one idea. Noonan is autosomal dominant, so there is no carrier thing. Noonan is a point mutation. It's a mutation. Okay, whatever mutation, RAS or RET or PTPN, some mutation. So because of which you can only detect it by gene mutation. That is the only way you can answer that. Apart from that, to study everything about Noonan and all is not possible. So it's again a reproductive kind of question, reproductive endocrine question, but kind of if you have worked and you have the census, you can answer. Proteinuria with diabetes, they are looking out for the answer of ARB. Cachexia with pneumonia, high protein, calorie dense central feeds. That is basically the answer, and the other options were actually very easy. We'll come to that question also later on. Patient operated previously for a parathyroid adenoma, presented with abdominal pain, dyspepsia, and a gastrin value which is extremely high. So this is basically MEN syndrome, MEN1 syndrome. Endoscopy showed duodenal, which means it's a duodenal lesion. So will you do surgery in a pancreatic issue, which is a neuroendocrine tumor, which is an enteropancreatic neuroendocrine tumor? We have mentioned this very clearly, that in a MEN syndrome, there is no point in doing surgery. We are having small tumors which are in the duodenum. So high dose PPI is what we use, and surgery is recommended only if the lesion is more than 2 centimeters. It's a very, very clear thing, and I mean, all of you would know that as well. So it's a high dose PPI. This I am myself taught you so many number of times. Non-MEN1 disease means, of course, you can, but MEN1 disease, no. Spotter with FGFR3. This is called trident hand achondroplasia. Some few pediatric questions were there, 1 or 2 questions. Lissencephaly was also there. Not possible, man. Then lungs, you don't have to study anything, because routine water rounds question, no, gold based question, gold 1, 2, 3, 4 question. FE1 is actually 55%. So you know that gold 1 is more than or equal to 80%, gold 2 is 50 to 80%, gold 3 is 30 to 50%, and gold 4 is less than 30%. So this was gold 2 that they wanted it on. Just that one question. Second question was young boy asthma not improving, AVPA routine, everybody answered. TH2 pathway, interleukin 4, 5, and 13, which we discussed so many number of times. 13 was asked. UIP, what is least common? That's more of a rheumatology question. UIP is classically seen with our idiopathic pulmonary fibrosis. In rheumatology, it is all about rheumatoid arthritis. Others can have UIP, but systemic sclerosis generally NSIP, but sometimes it can be UIP. So these are 3 things, and they gave the option of sarcoid, and they gave it as upper lobe. So it's very clear. Upper lobe NSIP is always sarcoid, because upper lobe involvement, NSIP kind of an involvement means it is sarcoid very clearly. IPF is UIP 100%, RA is lower lobe and it is UIP 100%. Systemic sclerosis is NSIP greater than UIP and it is also lower lobe. Yes, there are only 2 rheumatological conditions where the upper lobe is involved, and that is ankylosing spondylitis and sarcoidosis. Okay, hematology, there is a significant shift to this time. That significant shift to this time is basically that they have gone away from onco part of hematology. The tumors have all gone to the oncology side. So they haven't asked a single question on that. That meant that the so-called questions that they've asked are pure hematology, which makes it actually a little tough. Iron deficiency anemia with thrombocytosis. What is the next step to treat iron deficiency? Because thrombocytosis is a acute phase reactant, very non-specific. You don't have to do anything for that. Most commonly associated with ischemic stroke, inherited condition or acquired condition. The other 3 options they gave were factor V-laden mutation, antithrombin 3, protein C deficiency. They are all venous thrombosis. Arterial thrombosis and venous thrombosis combined. Most important cause, most common cause is APS itself. It's a very easy question. This was tough. I really have no idea why they asked, because acute GVHD, if it is not responding to steroid, I was thinking that like based on the trials or something, you put the patient in some trial or anything. I don't know, there was a drug even approved for that. And the answer is ruxolitinib, because that has been approved for acute GVHD. So that's a real tough question. That means not responding with steroid. Sickle cell on the smear, what is the best drug? Again, a tough question because voxelotor and hydroxyurea both are correct. Hydroxyurea is used in India more. The best efficient drug which inhibits HbS polymerization and all that is voxelotor. Whether they meant voxelotor or hydroxyurea, I'm not sure. Best drug, if you're asking me, is voxelotor. Again, tough questions. So, two questions are very tough. The other three are very easy. HbLC was given and HbS was actually speaking very high and HbA levels were only 40%. Clear sickle cell disease. Malignancy was given and TTP kind of picture with the microangiopathic hematuria, thrombocytopenia, renal failure with neurological features and all. Pakka TTP picture was given. And the TTP picture, they've asked you what is that you have to be doing. So, it's plasmapheresis, no doubt. And systemic mastocytosis is a question which is generally very tough, but this question was very easy because they just asked you how do you diagnose this. You see, you demonstrate mast cells on the bone marrow, cutaneous mastocytosis on the skin, and you demonstrate bone marrow. Then c-kit and other things were given, but gold standard or the best diagnosis was asked. A diagnosis based on mast cells. So these are all questions which are from topics which are not very familiar to us, but still we can get away if we have reasonable knowledge. These are two questions which I found tough. So sickle and thal they'll begin to ask now because that is pure hematology. So next time around when you study hematology, I think the focus has to shift. But again, that's what I'm trying to tell you. When you are studying as a PG resident, this is your opportunity to study hematology. So don't think that this is not important for NEET SS and stop studying that. Please don't do that. It's only leading up to the exam that you have to do that. Otherwise, it's a great opportunity. You've got some excellent videos by our faculty, hematology faculty from AMC's, again done superb videos. So because of which I really want you to actually sit and watch those videos because they will give you a lot of insight with respect to the subject, develop interest in the subject. I have done my videos as well. So may take you to a completely new world where a new career may open up. After CABG, cholesterol embolism, urine finding. Nephrology, I think you should get 100%. Okay, there is no way you can miss a question. All are very easy questions. Eosinophiliuria. Tumor lysis syndrome is Caro-Bishop score. We've discussed about this under AK. I've discussed DLS and told about the score and what happens to phosphorus, potassium, magnesium increase and calcium decrease. Then superior vena cava obstruction syndrome. What is least commonly associated with that? This is a little tough because lung, I think everybody knows. Thymus, I think we've discussed so many times. Lymphoma also. Breast is actually the least common. Breast is not so commonly associated. See, bronchogenic carcinoma, mediastinal mass, lymphoma, then only comes metastatic CA, which again I think most people got. Treatment for cholangiocarcinoma, no idea, man. I have no idea what the question is. But most of the students said that the patient is not somebody who can be taken for palliation. It's otherwise having a reasonably good general status, because of which they mark the answer as gemcitabine and cisplatin. But God alone knows what is the answer. Young patient with hypertension, hypertensive retinopathy, what will guide therapy? Hypertension with target organ damage means you have to look for secondary causes. Endocrine cause, renal cause. Under that, endocrine cause is Cons, which is the first thing to come to mind. Renal is about glomerular disease as well as about vascular disease. So urine protein is definite marker to see for whether you are having a renal involvement. Cons like kind of thing is there, that is also correct, but the other options were not in sync. So I've always told you, whenever there is a target organ damage disproportionate to degree and duration of renal failure, that's always equal to a secondary cause. Target organ damage disproportionate to degree and duration of hypertension, that is always a secondary cause. Secondary cause can be endorenal, etc., etc. So that's the beauty of studying nephro. If I had studied any other subject, I am saying 100% again and again, if I had studied any other subject apart from nephro for those 3 years, I wouldn't have been able to draw a connection with any other science in this world. That means I would have become a pure rheumatologist or a pure endocrinologist who knows everything about endocrinology but doesn't know about the other sciences. That is perfectly okay, 100% okay. But if you want to stay in medicine, you have to either do medicine and then sit with medicine, or you have to do nephrology from a top tier college. That's also very important, because if you're not getting any cross consultations, if you're not seeing the other department PGs, and if you're not attending to calls from the other departments, you obviously can't do. But once you are in nephrology and once you are in post-transplant, which is once again full medicine, that will give you the confidence to approach the other subjects as well, because you are constantly in sync. Our post-transplant patients have had MI of different types. I have seen uremic patients having uremic pericarditis. We have actually gone to the cardiology department so many number of times to get echoes done, to actually have, when we have problems inside procedures, especially you keep the guide wire inside and come and all, you can always go to cardiology and seek their help. So we are always in touch with every department. We are in touch with all the departments. So that's, I think, the beauty of nephrology. RAS, this question again, wordings are not clear. This was creating a lot of havoc on the day of the exam. That's why we always keep quiet on the day of the exam, because we really don't know the question. Gold standard is always angio. If this is the option, then you don't have to think of anything. Doppler has got good sensitivity, not specificity. CT with reconstruction has higher radiation exposure. Captoperal renogram is and all not done by anybody. It's for lateralization or to check for whether there is lateralization. So RAS investigations, if this is the question, B is the answer. But I don't know whether they've given more than one correct answer and try to confuse you. This from the middle of your sleep, you should be able to answer. Dysmorphic RBC is 45-1 rule, more than equal to 40% dysmorphic RBC, more than equal to 5% acanthocytes, or even one single RBC cast is glomerular. Isomorphic RBC, crinated RBC, everything is euro. Okay. Cystitis you are having with a 3 to 4 millimeter renal stone means what? You just have to manage medically. Nothing else you have to do. It's just trying to distract you. Nothing more. After PCI, again developing rash, eosinophilia, and of course the patient developing increased renal failure, all part of your post-angio, all that is all equal to cholesterol embolism, atherosclerotic renal disease. One module we have done on that. Least common cause of pain in ADPKD, I think everybody will know. ADPKD has no chance for malignancy. ADPKD pain is due to cyst rupture, cyst hemorrhage, peritonitis, stones, UTI and all that. Simple question on Parkinsonism. Parkinsonism always starts asymmetrically and it is asymmetrical motor symptoms, and then on the patient has the other kind of symptoms coming into picture. It is early onset symmetry, that is absolutely wrong. Stagnant is absolutely wrong. Early onset L-DOPA induced dyskinesia and all absolutely not possible. Even that is about PD plus syndrome. Treatment for cancer related neuropathy, there is no data on this actually speaking. I myself searched for. If I were sitting for the exam, I would have written 100% gabapentin only. But then I searched and found out that some other drugs are also approved, etc., etc. But I think most people got this right. Unilateral headache, sonophobia, osmophobia, photophobia. Everything in favor of migraine only. Otherwise, itself the other three are taxed. No, trigeminal autonomic cephalgias. They have autonomic symptoms. So obviously not. Then you have few questions which Bashek has discussed. Subacute combined degeneration mimicking Alzheimer's disease, which I think everybody has mentioned. I think I have told, he has told 100 times that there are people who behave like Alzheimer's. So reversible cause of dementia to be ruled out, and B12 is one very important thing. Image of MR spectroscopy, which everybody can identify. Lissencephaly not possible unless and until you know. Glutaric acidemia completely impossible. Cavernous angioma completely impossible. Tuberous sclerosis with adenoma sebaceum megapattern, I think all of you would have got it right. These three questions in neuro are impossible. Glutaric acidemia causing dystonia and macrocephaly and all that, I have no idea whatsoever. And ocular telangiectasia and cavernous angioma question is a 1 out of 2 thing. There are 2 questions, options confusing in that. So based on that, you can actually answer. So these are again few questions where you have no idea. So till now, I think we've seen at least 15 questions like that, wherein you have absolutely no idea which way to go, what to do. Elderly with metastasis on palliative treatment for pain, subscribe morphine. Maximum dose, determinant is respiratory depression. This high anion gap is there. So ethanol, ethylene glycol, methanol are all right. Lithium doesn't produce high anion gaps. All these are very easy things. Bilaterally small pupil unconscious patient responding partially to naloxone and flumazenil. Naloxone partial response means that with opium something else is there. Flumazenil is there. So amphetamine has basically got nothing to do with this, and tachycardia, serotonin syndrome will be there, not mentioned in the patient. So it is opium with barbiturate. Okay, pure opium means there should be good response, and barbiturate has no antidote. We can do, I think, 2-3 videos, I think, on poisoning. I think in the next 2 to 3 months, we'll come up with that. AI limitation for use in malignancy, can't detect all types of cancer. Can you detect leukemia, lymphoma with AI? Obviously not. Now, atropa belladonna poisoning, physostigmine, of course, I need not tell you, all this is MBBS stuff. Acid burns, will we go for blind nasal intubation? Definitely not. Refeeding syndrome we've seen. Sepsis with cachexia requires high protein, calorie dense nutrition. So high protein, calorie dense to actually manage sepsis. This was the question. So malnourished patient started on enteral feeding, developed pedal edema due to salt and water retention, hypoalbuminemia. He developed altered sensorium, erectile abnormality to look for. Refeeding syndrome, everything is phosphorus. Although the patient can have mild hyponat, mild hypocal, mild hypomagnesemia, but all that is not significant. The moment you think of this, you think of only phosphorus. Everything and anything relating to the disease is phosphorus. Opioid-induced constipation malignancy, of course, peripheral mu antagonists like methyl naltrexone. I think all of you know that IV naloxone, naltrexone, everything is there, but opioid-induced constipation is typically managed with peripheral, mu antagonist, because mu is the receptor that works here, and it is methyl naltrexone that we use. Again, for people who have not studied anything about poisoning for their MD exam, they may find it a little tough, but generally for our MD exam, we do have an idea about these routine poisoning stuff, basic things, nothing more. SOFA score and all, if you don't answer means, I don't know what you're doing in medicine. SOFA score, QSOFA is what we use now. So BP is there, respiratory rate is there, altered ventilation is there. Procal has nothing to do with QSOFA score. Okay. So what are the area under the curve from midline to +2 standard deviation? 95%. Odds is equal to relative risk under your case control study. And type 1 error is false positive. Type 2 error is false negative. So when null hypothesis is true but you reject it, that is called type 1 error. Null hypothesis is, failing to reject a false null hypothesis or false negative is what we call as type 2. Which again is something which everybody knows. So don't have to study any kind of statistics. Basic 3 questions I've asked and almost everybody has got it right. So it's your overall knowledge that actually matters. And finally, we go to our set of rheumatology questions. I think rheumatology questions are again very easy. I think only 1 or 2 questions here and there are tough, and you don't have to watch the rheumatology videos. Even medicine videos would suffice. RA patient getting pregnant, what have we discussed? Leflunomide very embryotoxic, methotrexate completely contraindicated. Stopping all DMARDs is not required. HCQ is okay. Sulfasalazine is okay. So HCQ and sulfasalazine, low dose steroid is also okay. So stop methotrexate. Stop all DMARDs and give steroid wrong. Switch to biologic wrong. Stop methotrexate okay. Stop methotrexate and sulfasalazine and add low dose steroid. HCQ is also okay. But if you're planning conception, planning pregnancy, sulfasalazine as per recent studies can all be used. So there is no harm in using sulfasalazine. It is only to be stopped if you're having G6PD deficiency and all that. Generally not required. Reactive arthritis, salmonella or shigella, whatever, that is the answer. Then your conjunctival painless shallow ulcers and all that. Keratoderma blendragicum was the option, and that is a very clear image and very easy reactive arthritis question. Then 60-year-old male with RA on methotrexate presents with progressive breathlessness and dry cough, and you are having end inspiratory crackles, which means that what is there? ILD is there. Methotrexate induced fibrosis? Absolutely not. It is a hypersensitivity thing, no fibrosis. Response well to steroid? No, because it is UIP, doesn't respond to steroid. End inspiratory cause crackles? No, cause crackles are seen in bronchiectasis. And honeycombing is irreversible? Yes, honeycombing with cystic changes, traction bronchiectasis, loss of lung architecture. That is what is equal to UIP. Discussed so many number of times. A patient presented with arthritis with both PIP, DIP, erosion, newborn formation. More than enough to mark the answer is psoriatic arthritis. No discussion itself required. 32 or see, the questions are actually long. That's a problem. So you may actually spend a lot of time reading the question, when in reality what they want to know may be a very small thing. Low back pain improves with movement, which is basically equal to inflammatory back pain. Young patient, alternative buttock pain. The moment you hear this, ankylosing spondylitis. This was actually a tough question. Again, on the day of the exam, this was something that was creating a lot of havoc in many of the groups, etc. And I am actually not part of any group, and so I'm very happy. The thing is that they are asking a question on ANCA vasculitis about a GPA kind of a question. That means Wegener's granulomatosis. What do you use for induction? Induction is with steroid and cyclophosphamide or steroid and rituximab. Both are actually okay depending on the individual patient. But pulsing is very important. You can't just give oral steroids. So because they've given methylprednisolone pulse followed by oral prednisolone, then it is of course the answer. But if it is steroid and rituximab versus steroid and cyclophosphamide, nobody can give you the answer. Generally, we all go with steroid and cyclophosphamide also only. Okay, IV is only what we use, and there are so many trials and all that. It's not required at your level. Cyclops is actually shown oral and IV are equal, but we go for IV only. And rituximab plus oral glucocorticoids for all patients is induction? Definitely not. It is cyclo that we use generally, but both are equal status. But pulsing is very important. A patient presents with widespread pain and multiple comorbidities, of course fibromyalgia. And fibromyalgia will have pain worsened by activity, stiffness and all nothing. It is pain sensitization, increased by sleep disturbance and hundreds of comorbidities. A woman presents with widespread pain, multiple tender points and all, fibromyalgia. One module I have done under rheumatology. Even if you have not seen that module also, functional fibromyalgia, female, 9:1, everything that is. IgG4 related disease, at the end of that management part, I have told you very clearly, steroid responsive, but then relapses. When it relapses, retux. Okay. Diffuse scleroderma. This is a slightly tough question because diffuse scleroderma they have given here, and they've given a FVC of 50%, DLC of 30%, and right ventricular hypertrophy, prominent pulmonary artery, pulmonary hypertension. So essentially, this is a patient who has a diffuse scleroderma with ILD associated pulmonary hypertension, which is type 3 pulmonary hypertension. And what do you have to do for that is what they are asking. If it is a primary pulmonary hypertension, of course, then I'll give the patient Bosentan and all that. So that has got no value. Should I treat this? Yes, I should treat this because it is NSIP, and NSIP responds to steroid and MMF or steroid and cyclophosphamide with nintedanib also. So of course I have to treat. Should I give the patient steroid or should I give the patient cyclophosphamide? That's the question. What is the appropriate next step? See, as far as scleroderma is concerned, steroid with steroid with cyclophosphamide or steroid with MMF is what I'm going to use with nintedanib also. But theoretically speaking, there is a problem in giving steroid because steroids can actually increase the risk for scleroderma renal crisis. And more important than steroid in the management of ILD due to NSIP is MMF or cyclophosphamide. Because of that, the answer is cyclophosphamide here. Although many people have written steroid and you can't say steroid is completely wrong. For our patients, what we do is we give steroid and cyclophosphamide or steroid and MMF and nintedanib is what we give. But again, theoretically, there is a risk of SRC. Because of that, I think the answer they want is cyclophosphamide. This question we already have seen, right? That means pattern is seen in all the following conditions except lower lobe is not involved itself means it is sarcoidosis, and UIP is what we see in the other conditions. NSIP is what we see in sarcoid. But remember, in scleroderma, most common is NSIP, but you can get UIP. Sapho syndrome is a slightly tough question because initial treatment, I have not taught about Sapho syndrome. I've told about the manifestations, synovitis, acne and pustulosis and all that. But the initial treatment is NSAID. So this I'm sorry because I think many of you have got it right still. But when you get a question in rheumatology that I have not discussed, I really feel bad about it because I should have told, and it's not common to see also. So as a PG, you wouldn't have seen. Rapidly progressive ILD, of course, with which myocyte specific antibody is always anti-MDF5. Joey synthetase syndrome, different gamma paraneoplastic, MI2 is routine dermatomyositis, and we've had umpteen discussions on that. If you get these things wrong, then you better not tell that you are my student. Okay, then what is this? This is equal to acute onset monoarthritis with joint pain, erythema, swelling, suggestive of gout, synovial fluid analysis. Preferred initial treatment for acute gouty arthritis, anyway, NSAID. Okay. Patient presents with fever, arthritis, salmon colored rash. This is specifically something that we have discussed, CD25 and all that. This is called AOSD, adult onset Still's disease. This is another thing that I have not taught. Maybe because I am not a kind of person who knows so much about these things. These are Nair's impingement test or the test. These either one question has actually come, correct match, Nair test and that, because I have no idea about orthopedics. So next time around, we'll actually do a small module with Abbas Ali, I think, or one of the orthopedic people to actually speaking tell you about these tests. I have not done any of these tests and I have no idea. I don't believe this is rheumatology. This is orthopedics. I'm very sorry this has come for the exam, so we'll get a module done on that. Actually, it is Nair's test that they wanted to test out here of the subacromial impingement. Cancer-associated cachexia, again, discussed so many number of times. Th2 inflammation, interleukin 4, 5 and 13. This is actually speaking very unfair because we've done so many modules on primary immunodeficiency. Almost 9 modules are there, and even a concise immunology section I've discussed about that, and we've discussed everything about primary immunodeficiencies, and finally they ask a question wherein we don't know what is the correct answer. Because recurrent cutaneous infections, normal immunoglobulin levels, peripheral neuropathy, low C3 can be seen in CVID as well as in C1q deficiency. But because autoimmune thyroid disease is there, an adult patient I suppose, I would still write CVID. Though C1q deficiency can be there, autoimmune thyroid disease is not there in that. And child is what is that we see with respect to it. So I personally feel the answer would be CVID. Again, I wouldn't ask you to see that in toto, but still possible to watch that because you're sure to get a question. And I have done 2 versions of that, one detailed version and one concise version also. Anaphylaxis, leukotriene C4, systemic mastocytosis, bone marrow infiltrate of mast cells. DVT, APLA, of course, as you know, low molecular weight heparin or heparin, and then WARF to keep an INR of somewhere around 2 to 3. Okay, so low molecular heparin followed by WARF. There is no way that you can skip WARF, no way. And the easiest question of the exam, NADS, TNA, SLE, okay. Swan neck deformity was another photo that they asked for the exam. And this is a question which some people had a confusion with respect to whether it is amyloid or whether it is RA associated ulcer. See, RA vasculitis, I told you, long-standing RA, splinter hemorrhage, telangiectasias, ulcers, medium vessel vasculitis involvement, rituximab response and all that. If they want the answer as amyloid, they should definitely mention painful lesions are classical of amyloid. If they want an answer as amyloid, they should mention AA amyloid, proteinuria, membranous nephropathy. If they want an answer as amyloid, they should mention about something like autonomic nervous system involvement. When nothing like that is given. So because of that, I will still mark it as RA vasculitis. Okay. Poor prognostic factor in RA. Again, this question is actually speaking except, or they got a question wrong, because joint erosion, RF factor, anti-CCP are all basically poor prognosis. Early methotrexate usage is the only one that is not applicable here. Okay, so on that note, we have tried discussing all the questions, whatever questions that have come to us. I think in fact all the 150 questions we have tried to discuss here. What I have understood is 20 questions or so, not even 20, around 20 questions are really tough or really in that zone which you can't answer, which is a specialty level. Apart from this, cardiology also we had few questions like restricted cardiomyopathy, myeloma, donorobicin. All these are basically medicine only. The tough cardiology questions came from cardiac resynchronization, which is I think a tough question. Otherwise, MR question which has been taught in detail, or when to do surgery in MR, the 60-40 rule which is again been taught in detail, about JVP being normal in acute MR, which is always wrong, the early systolic murmur in MR, cocaine intoxication, all that. These are all basically things which have been taught and things which are actually very simple. So what I can actually tell you right at the end of this discussion is that we should evolve from preparing for an MCQ exam to actually doing our course thoroughly with proper purpose, proper intent, and knowing things in a way that we can use them for our entire life, because we are primarily medicine people. And we should get out of this shell of studying MCQ like we did for NEET UG and NEET PG, and doing concise modules, doing some kind of table study, and then thinking that we are actually very good MCQ people, because that is not what is warranted. That is absolutely not what that is warranted. That is for INI, and INI preparation strategies are different. We are talking of actually getting good holding during our PG, understanding things properly during our PG, having good grip on individual subjects during our PG, giving our final exam properly, giving our practicals properly, then taking a small break and deciding as to what we want. And once we fix on the fact that we want to become, say, cardiology, nephrology or something that way, then preparing for our NEET SS exam with the help of the NEET SS folder and also with the help of those videos to finally get a reasonable idea, knowing that this exam is totally unpredictable, has totally different standards each time, and has actually got totally different weightage areas each time. So unnecessarily sitting and laying X on top of this exam makes no sense, because 22 exam, 23 exam, 24 exam have nothing to do with each other. I mean, the 25 exam have nothing to do with each other. 3 exams that we have had are totally different. Now what we know is that for the exam pulmonology, critical care, oncology, you need not study, and the other subjects you have to study, which means this time they asked gastro and rheumat maximum, next time they may ask cardiology and nephrology maximum, which we are really not sure. So studying thoroughly is basically the most important part, and you have this wonderful material with you, you have the videos with you, we have the updated content, you have the updated content with you. Please do utilize that, please do come up with doubts, and please do discuss about it, and please discuss it with your seniors and juniors as well, rather than trying to read notes, rather than trying to read textbooks written by somebody somewhere at some point in time. Please get out of the jinx of having to underline and read notes. Please get out of that. Please mature out your spin, please mature more, and please come out of the jinx and try to kind of develop your own perspective, your own understanding. When I am talking of renal artery stenosis, I have my own understanding, my own perspective. You discuss that first, you see that first question discussed by Rizwan under his review recall on gastric varices, and you will understand that it is purely his perspective that he has presented. You look at Bashik or you look at Nishant, I think there's lots to learn from them, because they are presenting their own perspective. If you are reading a book, you are actually getting what is written by somebody else, that is his perspective. We are trying to actually become good solid physicians who have their own understanding about a given disease problem. Okay, otherwise for that matter we can study even rocket science, because books are available, it's written in English, you will study and you will understand something or the other, and tomorrow morning you will forget that also. So the most important message is to have good solid grounding, to study things properly, to use the videos during your MD days as well as thereafter, and then when you're stepping into NEET SS, using it as a guide, and again following the set of videos that we have recommended, and then to give the exam wholeheartedly and try and see where this actually takes you. So my biggest message at the end of the whole thing is to try and watch as many videos possible. Because for a NEET PG aspirant, I never tell them to actually do that. I tell them to study. For a NEET PG exam, we generally don't actually tell them that way, because they have their own methodology preparation and they are actually a little bit more younger. At your level, I'm actually telling you to watch, because that can create a huge impact in you. NEET PG person is somehow trying to finish everything and get it done and go and get a PG seat and run away from here. In your case, it is not that way. You're all basically here. You're not going to run away anyway. You have to be here. And for you to be here, the better you are, the more knowledgeable you are, the more solid you are, I think you are going to be more wanted and you're going to be more on demand. So in that way, try and watch as much possible and develop a liking towards the faculties as well as towards the subject. I think that should keep you in good stead. So hopefully the exam has gone well for you. The results are already out, so it's taken me some time to get all these questions and assimilate everything. So I'm happy that we've got all these questions, mostly I think, not all of them correct, and try to get an idea about the exam on the whole. So once again, thank you for listening, and wishing you the very best.